frozen. Okay.
Somebody frozen?
Yeah, but it unfroze.
All right.
Okay.
Okay,
Well,
good.
I got it.
I think we're live now. Let's see. So, yeah, welcome to Monday, January 15th, Solid Ground live stream. It is our second of the, well, it's actually our first live stream of the new year because we recorded our New Year's Day and then we took the 8th off. So we took the second week off. So this is a brand new year and it's our second year doing Solid Ground. So I think that's very exciting. Welcome, everybody.
Yes. Happy New Year.
Yeah, Happy New Year. Happy 2024. And we have Jamie Reed with us today. Jamie Reed is a whistleblower, a former clinical case manager for a youth pediatric transgender clinic at the Philadelphia Children's Hospital?
St. Louis.
St. Louis. Okay.
Yeah.
And you have done a lot of podcasts lately and been out there with the story and with the passion that you have around this issue. There's plenty of places where people can go and get all of that information. And if you have any favorite links that you want to offer up, maybe you could tell people where they could follow your story.
I really enjoyed the trigonometry podcast. I had no idea what to expect with those two. And but I really enjoyed speaking with them. Transparency was the first podcast I ever did with Aaron Terrell and Aaron Kimberly. I thought it was a great episode. I also loved that they both emailed me directly individually asking me to come on, not knowing that the other one was also emailing. So they're like trying to beat each other to it. So I think Aaron Terrell won, I think, on that one.
Well, that's awesome. Yeah. And I was just actually listening to you on Gender, a Wider Lens, and that was shaping up to be a really great conversation. I think I'm about halfway through it right now.
Yeah.
But your story is, I think, really compelling, partly because the position that you come from is at when you went into this, you really thought that these treatments were very helpful for some people, but you expected that there was a high level of rigor being done in order to ascertain who is going to actually be benefited from some of these youth gender treatments. And as you came to work in this field, you saw a completely different picture. And now you've been very outspoken around what's going on and the need to be and I guess the need for us to pay more attention to this issue. And I really enjoyed your speech at GenSpect because you come from a left of center position and you made that very clear. And I think that's really an important bridge building for a lot of people who see this as a left-right issue.
Yeah, I don't know how to help break us out of that narrative. One of the things I find frustrating every single news article I read is that it just goes back to this claim that this is a right-left issue, and I don't see it. I don't see it with all of the people I interact with in my daily life. I don't see it in the science. I think it's a real detriment to open conversation to have it painted in such a way.
I was actually curious because I saw your piece, I think it was in the Free Press, regarding your particular, political orientation. I'm curious, like, the response to that. I haven't gone and read the comments lately. So I'm wondering, like, how did that land?
I think the Free Press has its own interesting readership. Barry, who started it, came from the New York Times. I think that she has her own, I don't want to speak for her, but I feel like a little bit of a libertarian kind of bend. I feel like what we see, if you especially look in the comment section, is that there is an openness for those who are willing to listen, to acknowledge that this really does span party lines. And I think that we're seeing that in polling too. So when you see some of these polls coming out from the general public, if worded in a neutral way, most Americans are not in support of permanent medical changes to pediatric or adolescent patients. And the thing that is difficult is basically all of the medical treatments that are given are permanent. So if you are opposed to permanent medical changes, you cannot just stop with, a ban on surgery. It's cross-sex hormones, and especially it's the puberty blockers directly to cross-sex hormones pathway too.
And speaking of puberty blockers, I know Jennifer had some specific questions or some maybe broad questions, and I'm going to interrupt the flow here because I forgot to ask one of you to let people know who we are. What is Solid Ground? What is
who are these strange people?
Yeah.
So Solid Ground is a peer support community, and we are here to help people navigate the divisive impacts of oppressive ideologies such as critical social justice. And you can join us for $5 a month at solidgroundsupport.com. We run 3 peer support groups per week. And we also do our live stream weekly on Mondays. And we'd be very happy to meet you. The groups are great. We talk about all different kinds of issues and challenges that we're facing. A lot of people are still facing these challenges in the workplace of navigating critical social justice being imposed upon them. And we're here to help each other with that.
Excellent. Thank you. And hi in the chat to Sininkari. Is it Sininkari? Am I pronouncing that right? In Finland. Hello, Helena. Hello, Ninja Kitty. And yeah, Jennifer, did you have, do you want to start off?
Oh, yeah. So I am concerned about the whole trans phenomenon for many reasons. But one of the things that concerns me is there's a lot of people who still believe that if you give a child puberty blockers, that this just pauses puberty. That's what we're being sold. And it gives them a chance to decide. And then everything will just go back to normal. If they decide, oh, I'm completely comfortable in the body I'm born in, you just take them off the puberty blockers and everything goes back to normal. And the same thing is sort of being sold with the cross-sex hormones. And so I'm wondering if you could speak to that and to the long-term effects of both the puberty blockers and the cross-sex hormones.
So let's separate them out first. So
Please.
Puberty blockers first. Historically, puberty blockers were used in what is called the Dutch protocol. So never in a million years did I think that I would be my age talking about the Netherlands and the Dutch as often as I do. But there were clinicians in the Netherlands, Dutch clinicians, who created a protocol, and their protocol is what all of this is based on. And the concept was that they were going to give children puberty blockers as part of the assessment period. So it was supposed to be blocking puberty to do more therapy and provide a time to think, which is the title of Hannah Barnes' book from the Tavistock Clinic in England. So initially, puberty blockers were thought of as this period of assessment. When you are digging in more, you're working therapeutically, you're really trying to do more assessment and see, is this a long-term identity or issue that a young person's having? So initially, they thought this was a pause. That's kind of how they framed it and how they looked at it. Even kids who are given puberty blockers for precocious puberty still experience long-term, sometimes detrimental, significant effects. There's a few articles about this. There have been reports to the FDA. Individuals who are given puberty blockers for the FDA kind of right reason still have long-term harms. So the Dutch thought kids would go on this. It would be the pause. We'd do more therapy. Probably a number of them would come off. That's where we get this idea that you can just come off and everything goes back to normal. What we see in most of the data that we do have, which is not very much, is that in England, pretty much you can say with confidence over 90% of kids who are put on puberty blockers go on directly to cross-sex hormones. It was also directly what we were seeing in my center. It is not a pause. It is not a time to think. It is step one in a process. I sometimes kind of view it as a funnel that once somebody falls in at the top, you cannot get out. It just goes down the funnel, down the funnel, down the funnel. So they fall in the funnel, they start the puberty blocker, everyone goes on to cross-sex hormones. And this is where this idea that it's just a pause or that everything goes back to normal goes really haywire, because most of the problems with sterilizing kids comes in when we do a puberty blocker at Tanner stage 2 and we go right to cross-sex hormones. So Tanner stages is the different stages of puberty that they can judge where your kid is at. Tanner 5 is the highest, Tanner 1, 0, 1, 2, 3, 4, 5. So 5, you would think of probably a 16, 17-year-old boy would be at Tanner 5. Most girls go through puberty earlier than boys. But you can be at a quite young age, 7, 6, 7, 8, starting puberty blockers. And what is truly irreversible is cross-sex hormones. So we gave out a colorful, bright handout that kind of sold these ideas to patients, but it listed the irreversible changes, the partially reversible, the reversible changes. There are some significant irreversible changes that start quite quickly with testosterone. Within 3 months, you're going to see the voice drop. This is because there's actual thickening and physical changes that are occurring on the voice box, things that are not reversible, and they can happen quickly. The other thing that happens quite quickly with testosterone is the clitoris grows into what we were calling a microphallus. So it can grow a couple centimeters, it can get length to it, it can have some detrimental effects. It can sometimes protrude outside of the vulva, cause chafing and rubbing, but you will see clitoral growth quite quickly that is also completely irreversible. So then with testosterone, you will see the body fat will actually start to move. So it'll move in women, it's more pear-shaped, more along the hips, the thighs. That'll start moving into the abdomen. And abdominal fat is a little bit more dangerous than we know more dispersed fat. So that's where you see some of the cholesterol, the body fat actually moves around and changes. Body hair will start coming in all over. You'll see some changes to, facial hair, sideburns first. Some people will start growing facial hair. You'll see male pattern baldness. You'll see thinning of the hair, the crown of the hair. Thin skin will thicken up. It'll become more coarse. I can keep going. The inside of the vaginal canal will start to atrophy and start to have changes. A lot of people will report abdominal pain, cramping, their ovaries, their uterus. They'll have cramping and pain. Menstruation will cease. And these are real effects across the whole body too. We also have had, reports, patients on testosterone will report that they can no longer cry or that their emotional bandwidth really changes. So it goes from they feel flattened out, they feel like they get angry really quickly, or the only emotions that they have are anger, or just real flat effects. And some things that are not mentioned often is that patients also will report that they feel like their sexual orientation has changed. So patients who were maybe same-sex attracted, so women who were attracted to women will find being on testosterone for a while will shift their sexual attractions, which is hard for some people. And just a lot of these things are not reversible. And, the boys have their own set of changes with cross-sex hormones. The differences with the boys, there are so many different treatment, like drug options. That testosterone's really clear because it's kind of one and done. Everybody gets T in some form or another.
I just heard, I think yesterday, and I don't know, it was like a study of 25 people that they're thinking that it also might result in IQ dropping. I don't know
The
how.
puberty
I mean,
blockers.
25 person study is very small, and so I was like, I don't know if I should be spreading this, but that seemed, and the bone density has also been another issue, right?
Absolutely. So the puberty blocker and the IQ drop, I've seen a researcher present on this, and I feel like their reasoning was compelling that it definitely needs more research. And part of what they were explaining is that the brain has these certain periods of time where it does a lot of growth or pruning, I think is what the word that she used was, you create a lot of connections and then there's periods where you prune them back and you narrow in and you focus on some of those connections stronger. And basically, part of her hypothesis is just that there are stages in adolescence where those things have to occur. And if we pause or block those periods, there's no real good evidence that those catch up or can occur later.
Mhm.
And so, she did look at a number of studies and she was finding, some people were, I saw on X or Twitter, people were saying like, oh, well, it was a 7-point drop or a 10-point drop. I actually think that's
That's
really
pretty
significant.
significant. Yeah.
I mean, when you think about like,
Jeez.
yeah, I don't want my kids to have any IQ point drops. So
Yeah.
yeah, it definitely looks like there's more to it, and there's a real need for some much better research and evidence on that. And then, yes, there is known issues with bone density. Anyone put on a puberty blocker should be having something called a DEXA scan regularly. Again, it's another thing where the doctors will say, oh, well, you'll regain all of the loss once you stop the puberty blocker. But the idea that these are benign, simple, easy treatments is just, it's absolutely not true. These are very significant, have long-term impacts, and should always have been considered in a very serious way.
Does
Yeah,
the does
ahead.
the IQ return? Does the brain development catch up, or that's it? You've missed that window.
No, it looked like from the small studies that it doesn't come back. I mean, IQ is pretty set.
Yeah, yeah.
Well, and
And
I
so,
think to Deborah's point about the studies being small, one of the points that this researcher was making, it was Sally Baxendale in her presentation, she talks about the fact that there's not any evidence to say that these things are not causing these problems, and very little evidence at all around them. So we're actually in the middle of a great experiment, because these people who are saying that they're reversible have nothing to base that on.
It's like if
it
you think
reminds
about
me,
it. Oh, go ahead.
well, this is going to maybe show my age. It reminds me of this old book by Rachel Carson. It was called The Silent Spring. And she was one of those early pioneering ecologists that said it's not okay for you to put weird chemicals out into the environment and then demand that we prove that they're not safe. Her whole thesis was you have to prove something is safe before you ever use it. And I think
like
it's
that.
it's the reversal of the thought. We should not have been experimenting on this huge group of kids until we had proven all of this safety first. And what Sally's talking about is they're doing animal studies on some of these puberty blockers, like needing to go back to animal studies to prove safety.
Good
Yeah,
Lord.
I'm just thinking that's the precautionary principle. Yeah, like if you think about it, I mean, everything you've been saying, if this is the time of life when all these I mean, tissues, muscles, brain are developing. Like that's a process that takes time. You know, by the time you're an adult, not a lot is changing, but if you are inhibiting, like the body's forming still, you know, and if you're inhibiting that in some way, and it needs to be a certain sequence and things flow in at certain times and you've disrupted that. I mean, that's, you know, I mean, we're seeing it go on, but it's like you said, I can't remember how you said it, but it's sort of like, why are it like, you have to have a pretty good reason why you think this would work.
Yeah.
I have a couple of questions. First off, what you mentioned earlier was really interesting about the concept of the funnel, that once somebody goes on to puberty blockers, 90% of them go on to the cross-sex hormones. What's your sense of why that is?
Oh, I think that touches on the concepts about why social transition is not benign in and of itself. So, Hilary Cass talks about this in her interim report, the Cass report from England. But the idea with children, I think especially, is children believe what we tell them. They follow parents and they follow who we say are the professionals. Um, I mean, I teach my young kids, if I'm leaving you in the hands of the gymnastics teacher, that adult is in charge of you for the next half an hour. You know, like we teach kids who to listen to and what to, you know, kind of do. And when we give a kid this concept that they can socially transition, so we can change your name, and I mean name outside of a nickname. I'm not talking
Yeah.
about, you know, you call your kid, you know, like a nickname, but a whole kind of new birth, new name, new pronouns, and then to put a kid on a puberty blocker, there is you are not going to have but the rarest of rare kids ever be able to stop. We're asking a kid to basically stop a train heading down
Yeah,
the tracks.
I see.
And they just don't have that ability, comprehension, knowledge. Um, I had spoken to a patient who had socially transitioned and only had changed their name and pronouns. And and they had told me that they felt like they could not go back. Even if they wanted to, they could not go back. And because they saw their parents tell the teacher, they saw their parents tell everyone around them, they saw their parents, you know, fighting with the grandparents, and there had been
Oh.
so many mechanisms pulled for this change that the kid, uh, as much as they were regretting it and feeling like they wanted it to stop, they just felt like they couldn't stop it. And so for so many patients, you know, they feel like the puberty blocker is the start and then you just go on. But we also kind of sell it that way. The way that a gender center kinds of explains it is we're putting on a puberty blocker and then we talk about what age do we do cross-sex hormones. It's like it's just sold as
Uh,
that's the next step. That's how this
right.
works.
Right.
can-
Well, and I would think too that a lot of kids that are having this sense of, oh, I'm really a boy or I'm really a girl, that if they were allowed to just proceed through puberty naturally, that in and of itself might help them to step into and grow into, both physically and emotionally as well, the sex that they were born into. And they're
Yeah,
missing that opportunity to just go through a natural puberty, which might very well sort things out for them.
that was what you see if you look at some of the original data. When you see how many kids desisted, it was, you know, puberty for many was the desistance moment in time. But for so many of these kids, they're not also afforded the resiliency that's acquired in puberty.
That's right.
So some of the messaging from activists is like that puberty in and of itself is somehow the wrong puberty is like a torture, which is just we're not those are stages that kids go through, part of maturing and being resilient and learning how the body
Yeah.
changes and what do you have control over and what do you not have control over, and what does it mean to be in your body and what your body does. Those are hard things to do, but that's part of growing up is we have to do hard things.
It seems like there's also been this language around almost though as though there's this rights language, like there's a right to not have the puberty you're not supposed to have, or there's a right to not even have puberty or something. And then that becomes
that's
this
a
political
medicalization of development.
Yeah. But to make a political right out of it, it's, it's like, no, it's actually what bodies do.
Yeah. Well, are we always trying to control nature and somehow be not animals and be outside of the natural world?
That's right. That's a beautiful way of putting it. Yeah, thank you. Hey, what's your sense, Jamie, of why there is such a massive increase in the number of kids who are presenting with gender dysphoria? Because this used to be a very, very rare phenomenon. And I think you mentioned in the article in the Free Press, I can't remember how many gender clinics there used to be in the US, but then you said now there's over 100. Like, why? What's driving this, in your opinion?
The common phrase that's used is social contagion. I think the public kind of understands that. I think there are so many other elements to that. So, here's some kind of therapeutic word. So, you can see this as a culture-bound syndrome. You can see this as symptom pooling or symptom looping, where we offer through social media, through schools, through medicine, we offer basically these are the options to explain your distress. And we have shifted what the options we're handing off to kids are to explain your distress. And right now, one of the symptoms, one of the things that is rampant in our culture that we are messaging to them is, do you feel distress? Therefore, this is gender related. And some kids who even don't necessarily go in feeling distress can come out the other side having caught the distress. And what frustrates me to no end about people denying that there could be any element of social contagion is if you just look at other social science arenas, we know that suicide can be a social contagion, divorce can be a social contagion, marriage can be a social contagion. You can see pooled symptoms in we're humans. This is what we do.
That's right. Yeah.
And then another reason why, scientifically you can say there is an element of a social contagion just looking at this geographically on a map. You can see that there's certain geographical areas where this is pooling, and that goes back to infectious things are caught and infectious things are found in geographical spots. And so one of the things I found so interesting in some of the data coming out of our center was I was seeing a statistical high level of these are kids, white primarily, girls primarily, in middle class to upper middle class socioeconomic households in the first or second outer rings of suburbs had a high prevalence. They have health insurance, private health insurance. So we saw that kind of group, and then we saw the group of kids who are in foster care or have significant family trauma, family history, on state care. So you could see different pools of where these symptoms were pooling together. And so then if you start to kind of take that apart, what is it about, an inner or first ring suburb of upper middle class families? What do they have that could increase the likelihood of that contagion element? So you probably have teachers in your school who are woke, liberal, have uh, these
Yeah.
things in the classroom. You probably have a good cell phone. You probably live in a household where the internet is always on and it's not being cut off because, mom can't pay the bill. You probably have a significant amount of free time on your hands. You probably aren't caring for your younger sibling because mom has to work 2 jobs. I mean, you start thinking about what is it that allows these things pull together. And then, I think in our culture too, we just have these significant groups of adolescents who are experiencing a whole lot of distress. Um, and then when you added in the element of the pandemic, you also had a significant portion of adolescents who were then having their own visual seeing themselves looped back at them frequently. So there have been studies about um, eating disorders in adolescent girls. And part of that with the rise of social media is that they are photographing themselves more. They're seeing their own image brought back in front of their eyes. If you're going to school all day in a setting like this, you're looking at yourself all day compared to the others around you. There's just so many elements that kind of baked in this perfect storm for what we saw. And then from the activist side, this was the next civil rights movement. So then you also had this whole cohort of especially white girls who were trying to think of ways, and some of the boys who were trying to find ways to not be of the oppressor.
Mhm.
So how can I get out of being, in the civil rights kind of mindset? I don't want to be an oppressor. And so I can't change my race. I can't change my socioeconomic status. I can't change these things. But the one avenue that we opened up for kids is you can be queer. Um, and for some of them being gay or lesbian, there's actually activities that come along with that if you're not actually gay, kind of work themselves out that this is not comfortable, this isn't my thing. But to take on that queer, non-binary, trans identity was kind of a pathway for some of them.
And we've also seen how porn use can morph a person's sexuality or sexual appetites. And so we've got all these kids sitting at home with their computers, but that's an entirely different ball of wax, but I think it relates. It's interesting, what you're saying about these two disparate groups that you tended to find these clusters. And I wonder about the lack of adequate conditions for identity development that might come from being either too affluent or having, so you've got like the neglect on one side, and you've got people who don't have the right amount of adversity and experience. They have either too much or too little. And so you end up with these identity development, like sort of pockets that are experiencing this. And this is when I spoke with Eliza Mondegreen a couple of months ago on this channel, and she called it an idiom of distress. And I thought that was such a beautiful way to describe it. It's just such a succinct way to understand it. And it, similar to anorexia or bulimia, or the kind of eating disorders that we would have probably all seen among girls when we were teens. This is a similar sort of thing, but unlike that, when we were kids, we didn't have adults stepping in to say we're pro anorexia rights. We're pro, let's support you in your marginalized identity as an anorexic. And you are a truly anorexic. So let's get you the help that you need, because some people are really supposed to be very, very skinny, and clearly you're one of them. And you know, it's got some similarities, but also I think that there's this socio-political, like it's manifesting in the adults, the social contagion, at the same time as it's
Oh, yeah.
manifesting in the children.
Absolutely.
Absolutely.
Absolutely. Yeah. The adults are all thinking that, you know, these sort of middle and upper middle class adults all think that the thing to do as a good parent is to embrace your child's new identity, to support them, that sort of being a good parent and a good liberal and, you know, being an educated, sophisticated person, that's what you do. Some of them, I think, you know, even kind of think it's cool because, I mean, it's like, you've got a trans kid. That's the ultimate fashion accessory for somebody who's, you know, wants to virtue signal. Yeah, it's absolutely, it's with the adults too. But, you know, so the people that worked at that clinic with you, Jamie, and people that are working at all these other clinics, I'm assuming they know the same information you do about the long-term effects of puberty blockers and cross-sex hormones. So what is the difference between you saying, hey, wait a second, this is having some really negative effects. We need to rethink this. We need more research. We shouldn't be so quick to rush to this. And all the medical professionals and social workers and nurses who are you know, still advocating for this treatment, which does not have well-developed, well-researched protocols. What is the difference?
And do they even let themselves know about the other data? Like, I keep wondering if they just kind of go like that.
It is quite siloed, and it is quite, you know, I see what I want to see, or I search out what I want to search out.
Okay.
I think there's a couple, you know, elements in my own life. I think studying as I did in my undergraduate degree. So I studied cultural anthropology, and then part of my degree program is I did go and study abroad in West Africa. And one of the things I remember people talking about preparing for cultural immersion, or, you know, being in such a totally different place, is that there's these kind of steps where when when we first arrived, everything was amazing. Everything about the new place was so cool, and they did everything right, and it was just so great. And everything about where I came from was horrible. And then there was this total shift where everything they were doing was wrong, and you wish to go back home, and my home was perfect. And it's only after really being immersed in something and having this kind of cultural anthropological training that you come out on the other side and you can see the negatives and the positives in all cultures. You can see it in your own, you can see it where you're at, and you have this lens where you can start to almost have some objectivity about the world around you. And so I really credit a lot of my undergraduate coursework for being able to acknowledge the culture that I was within in this center. It was its own culture. Like, they intentionally hire LGBT people. There is we believe this, so therefore we're gonna keep digging in further. We're keep digging in further. Um, there's a lot of policing in these places. I imagine that you have, kind of experience in other kind of DEI workplaces. I was one of those people that went out and trained in the other divisions and trained the other medical staff about, you know, I specifically would say in the training, we are not here to be the language police, but, and then we'd put up a slide and be totalitarian about it now. But it just seemed like we were the best of the best. We knew the best info, and we were gonna be the best woke people on campus. And it self-fulfills and keeps going. And what was some of the things that were so interesting is that when people would start to reach their kind of breaking point. So there'd be a couple times when, we would have a patient come in who are asking for these, they're referred to as neo pronouns. So I know people who've read my piece are like, yes, there were patients who were asking for their pronouns to be mushroom, or their pronouns to be rock, or their pronouns to be it.
I thought you were going to say Zer. I've heard that. I didn't know mushroom.
No, they were saying their pronouns were rock. And
oh, holy shit. Good.
And so sometimes you would start, I laugh now, but I'd be in a training and we'd be training people like, you have to respect their pronouns. And every once in a while you'd get like the hardened nurse who's been in the ER for like 30 years, who's like, the nurse who, like, if your kid was shot, like, you would want no one else in the room except for her, because she could, like, she would say, like, she could save, she knew all of the things. She would be like, are you kidding me? Like, we're supposed to say what? And like, sometimes they would say things like, where is the line? And I really liked that. I really think about that in retrospect. Where was the line? And we were just letting these kids push it and push it and push it and push it further and further out. Our psychiatrist a couple times said, why are we humoring this? Where, those kind of things. But when it started to get into those extremes, that's still kind of my one hard, fast rule. I am not going to refer to a human being as it. I'm not going to be.
No,
I'm not going to be
dehumanizing.
I'm not going to be complicit in dehumanizing you. I'm not going to do it. But
I agree.
But those are, where's the bottom?
Where is the line? I think that's
where
such a good
is
point.
it? Yeah.
It's like these kids are looking for a backstop. What's this? Where am I safe? Where do I fit? I mean, I don't know. I know.
They
just
wanted to hear no from somebody.
They wanted to hear no.
They just wanted somebody to say no.
I watched this video. I think it was like an Epoch Times video, and it was this cute, like, heartwarming thing where this dad had just he'd just come out of incarceration after like 11 years. And there's this kid who's like 12 or 13. Like, this kid has always seen his dad through a plexiglass or on a phone or whatever, but he's sitting at the table. His dad comes up and sits next to him, and he's doing this double take. Like, is this real? And then the little kid just kind of, he lights up, and then he bursts into tears, and then he folds into himself. He like curls into himself, and the dad is sitting there, and he reaches out and tries to pull the kid, and the kid pulls back, and the dad doesn't give up. He pulls the kid onto his lap, and then the kid is like, okay, now I'm safe. And he wraps his arms around the dad. And it's so sweet. It was like, I had to watch this twice because it's so sweet. But what you're watching there is the adult knew what the kid needed, and the kid needed to feel safe. And he was saying to his dad, I don't trust this. I don't trust this. I'm going to trust me because I don't trust that you're really here. And I think about how much we need that in life, especially when we're kids, but from the people that we love. And there's this delicate balance of boundaries and respecting somebody else's body and their space and their thoughts about who they are. And I think that there's not an easy answer to this, but when you see a kid go all the way to mushroom, all the way to like absurd, it's the absurd, and you don't provide a stop for them, you're letting them go into free fall at that point.
You are. Yeah, I mean, it's like there's no bottom to it, and it's just I just think leads absolutely to insanity. I mean, what if somebody started saying they identify as a face slap, and to honor that identity, every time you greeted them and saw them, they wanted you to slap them across the face, and that was how they wished to be recognized and interacted with? Are you going to engage in that and slap them and abuse them because they're saying that's what they want? I would think that no, we would not do that.
Jamie, do you think this whole suicide thing, like, it just, people just lost all sense of anything because they're like, they're going to commit suicide? I mean, like, how much weight does that, this suicidality thing have over people allowing these things to go on?
I think the power of that is huge. If anyone has been following Ohio, the state of Ohio here, they had a bill to ban puberty blockers, cross-sex hormones, and surgery. And the governor, Governor DeWine, at the end of the day, he said he vetoed it, and it was about suicide. And he had had a child in his own life commit suicide, not over gender, but he knew that pain, and to him, he couldn't get past that fear, that myth, and I struggle with talking about this because I I know that there are contagions, that suicide can be contagious. But I sound like such a scientist, but from a data-driven perspective, suicides are about always more than one thing. So to just say it's gender, it's always about more than one thing. And then it comes into the things that we assess when someone is reporting that they're feeling suicidal. Do they have lethal means? Have they attempted before? Statistically speaking, it is not young girls who have the statistical risk of suicide. And most of the patients in these centers are girls, teens. They don't have access to lethal means. Their attempts are normally not very serious. They're more
Gestures.
they're more prone to be gestures or ideations. And not that those things don't deserve to be treated with care and caution, but I don't think that we need to be making public policy based on a fear-mongering mentality.
Yeah.
Well, and also just from a clinical perspective, if someone is suicidal and threatening that they're going to kill themselves if you don't give them some kind of intervention, and that intervention is something that has permanent consequences, you'd want to make sure that you stabilize that person so that you could give
Absolutely.
informed consent. So
That's
how can
right.
you possibly give informed consent
That's
to
right.
someone who is so distressed that they're threatening to kill themselves? Those things are antithetical.
Yeah. It's not quality care. It's not what we know is good care.
Mm-hmm. Mm-hmm.
Yeah.
Well, in the chat, it looks like a little while ago we were buffering, and so maybe there was a little bit of a disruption. Sorry about that. Thanks for sticking with us. And if, maybe I'll review this live stream later, and if it looks like there's a glitch in it, I'll just re-upload the recording instead of leaving the live up. Thanks for letting us know that. And I saw, it was kind of made me chuckle earlier. I think it was Joel Henry. He said, "Good morning from Boston. This show sure beats The View." So thank you. I thought that was pretty cute.
Hey, that could be a sort of our motto. We beat the view.
Sure beats the view.
I like that as a tagline.
Yeah.
I dig it.
Thank you to everybody who's engaging. Lots of, the Clue channel. They should have been told no during year number 1 of the idiocy, not in 2024. I think that's a good point. And I think that one of the things that, though, it's such a nuanced point, because when do we realize? And I really admire the perspective that you bring, Jamie, because there's still so much polarization around this issue. There's this, I think a lot of people fall on one side or the other. And really, there's such a gray area when we're talking about people's sense of identity and what kind of interventions we can access through medical technology, and where do you fall on that? I mean, it seems like on the one hand, it's similar to a lot of cosmetic procedures that people have been availing themselves of over the last, at least all of my lifetime. It's been a thing that if you're born with a really unfortunate deformity, you can get it fixed. And then at what point are you just monkeying around with perfection and trying to perfect something? So there's this whole spectrum of cosmetic intervention that, you'll see, like I remember the tabloids when I was a kid that would be in the newspaper, and you'd see some woman who's gone all the way to cat lady. She's done so much to herself. But then you see somebody else and you're like, wow, well, she had these horrible eye bags that made her look like she was tired all the time. And now she got them out, and look at her, she's fresh. And she's, so that's cosmetics. And so cosmetics meets gender and meets identity is this whole new field. And at what point there are trans people who are living very happily in their trans identity. I at least I believe that as adults, there are people who feel themselves, and who am I to judge what they feel for themselves? They feel for themselves that this was a good choice for them and that they live a better life because of it. And then there's kids. And do kids deserve the right to know what it feels like to be in an adult body before they make those kind of decisions? And then there's the hard question of males who, if they transition, if they really do feel that they would be benefited by gender affirming surgeries and therapies, they won't get the same kind of results if they avail themselves of it once they become a full grown man versus if they've done it as a teenager. And I'm not saying that I think that you should intervene with kids. I'm just saying there's a lot of complex questions that are being asked, and it's not such a simple, I don't know. I don't think it's as simple an issue as some people want to make it.
It's not simple at all. And Leslie, you are so well versed in this topic too. I mean, I think you know all of those historical kind of questions that got us here. But sometimes I do wonder if the Dutch, instead of looking younger, they could have been at a reflection point. So the reason why the Dutch started this concept at all with kids was that they were finding that adults who had transitioned were still struggling. And especially the boys who were trying to transition to be read by society as women were struggling with passing and feeling like they were being seen by society as women. I wish if we could turn back time, instead of going, oh, let's just try to intervene younger, they stopped there and started looking at the treatments as they were then. What were the long-term health outcomes? Were there other therapeutic interventions that could be used to help? Were there any societal things that could be shifted? So could we have looked at ways to broaden our ideas of gender nonconformity and become more accepting of gender nonconformity to help people live better functional lives instead of going backwards to the kids?
Yeah, that's where I think the cultural phenomenon piece comes in, is, how do we deal with this as a culture? Because I've been told that, in Thailand, they view men who transition to women, they don't view them as women, they view them as a third gender.
Mm-hmm.
And that's
Ladyboys.
considered okay. Yeah, the Thai lady boy. So part of this, I think, is how we conceptualize it that influences how we treat it. And to me, thinking, oh, we'll capture this early in childhood because that will help them when they're adults is still, I mean, what a high risk game that is, because we also know that the vast majority of people who are, identifying as the opposite sex, if left alone, they will desist. So,
but there's
very
this other
risky.
element. There's this other element to cultures that can have this liminal space for this third way that I think recognizes something about us as societal creatures. And there is something about the ability for a person to live in a disassociative state, and how long can one stay in that space. And so what we are trying to ask kids to do, some of the kids, especially the kids who were blocking cross-sex hormone surgery, we're asking them to take on the path of being stealth for the rest of their life. And then we're talking about, if you are stealth, then psychologically, how much I just know that there are elements of that stealth existence that can lead to feeling of imposter, or honesty, and who are you honest with and when are you honest. And I know that some of the feminists who, we don't agree on a lot, or we do agree, but I think there are elements that I don't fixate on as much. But one of the things that I have heard people say is that one of the reasons why some of the parents cannot let this go is because they have basically signed their kid up for this lie. And the way that they have to proceed is that all of us are going to lie also, that we've all agreed that they've created this social construct where we're all going to buy into it. And I think that's a part of society where we do have, these are free speech issues where we should be having these conversations. Did we all agree to that? Do we all agree to maybe um should we have gendered restrooms? Should we have all non-gendered restrooms? Should we have sex segregated spaces and sports? Like, we have to be able to have these conversations without just labeling somebody as a transphobe or somebody hated just because they
That's
want
right.
to actually have these conversations. These are conversations we need to have.
Right. Or doxing them or canceling them, trying to destroy them professionally because they want to explore these issues. Because part of the problem with this is these ideas have been adopted wholesale without any real conversation. I know in my previous workplace, we literally had no conversations about this. And we started having more and more people presenting as trans. And I questioned something in a meeting and was promptly told, but the model is affirmation. Well, we've never discussed the model, so I don't care. I have questions. I have things I want to say, and I am going to say those things. And I just think this is ridiculous. What else have we just accepted? We don't. And as therapists, your job is not to instantly affirm a client. You're always exploring things and trying to gain an understanding and help the client to gain an understanding and look at things through a different lens. Why is this the one thing that's not allowed to be explored? We just have to accept it wholesale and immediately celebrate it. That's ridiculous. We don't do that with anything else. So I think you're right. We have to have these conversations. We have to have them professionally. We have to have them as parents. All of this needs to be something where people can feel safe to discuss it without thinking they're going to be, canceled.
Yeah, absolutely. And I think that this kind of goes back to what you said earlier, Jamie, when you were describing your workplace culture, where you'd be shouted down or shut down real quick. Like there was a quick nipping, like it's not she, it's they. It's like this, you don't feel you'd be terrified in that kind of environment to voice anything that was in the like questioning. And it's the same on both ends of this. It's like, if I've seen this myself, because I do sort of want to explore all of this. I want to openly talk about it. I want to not be afraid to be curious about something or to say, well, what about this? But anytime I venture into the what about this territory, I get a flurry of comments that are nipping me right back to you have to think this way about trans. And most of this sphere that I've been existing in has been the gender critical, if you will, or the anti gender ideology sort of sphere. So it's on that side too. It's don't you dare have a nuanced position. And even if it's not a position, because I really don't know that I have a position, I have a curiosity. I have a sense that there's too far on either side.
Yeah.
One side you're impacting people's individual choice. The other side, you're impacting people's individual choice through coercive behavior on either side, through medical scandal and malpractice, or through denial of freedom of expression or whatever. So there is this, I think that it's critical that we create a space for nuanced conversation to occur, for people to spitball, for people to brainstorm, for people to be curious about what does it all mean.
I'm also curious, Jamie, too, since you're coming up to about a year since you whistle blew, if that's the past tense, are you seeing these spaces? I mean, obviously we're here talking about it, but are you seeing a little more room for the conversation? It seems like maybe the media, I don't know, like, are you hopeful about how there's more, so it's not just this blunt force instrument?
I've always been a hopeful person, just in general. So that's just part of my nature. But yes, I do see more room for nuance. I see more room for discussion. I also see strange political openings where, people can be in coalition with one another, maybe on this topic where they, aren't on any other. But then I love kind of the phrase like, you know, well, we don't agree on this, but thanks for having a conversation. And the more that I've heard that over the past year, the more I feel hopeful about our society as a whole. We're going into a presidential, which I think is scaring a lot of people. But what I would really like our leaders, people who are seeking our votes, to think about in both parties is to be open to the dialogue around these issues. The issue of medically interfering in kids' bodies, but this also touches on the rights of women, the rights of children to grow up, to be, have functional reproductive systems and to have healthy chances for sex lives of their own. These are big, weighty issues that we should be having dialogue around as grown-ups without just shouting one another down. And I think part of it is I'm trying to work with people every day to mirror that and to show how that works.
Well, it's time now. I know Jennifer's got her solid ground group right at 11 Pacific, which is what, 2 Eastern?
2 p.m. Yeah.
Yeah. And so we always conclude right at the hour. Jamie, it's been such a delight to have you with us. Thank you so much for doing a deep dive on some of these issues that we have really just kind of been playing on the surface of so far. And so you really helped to go deeper into, especially the issue of pediatric gender care and puberty blockers and what does it all mean. And when you were describing the list of, I was picturing like you in the fine print underneath of the pharmaceutical ad.
Yes.
Yeah. And like the voice sped up to 2 times.
Yep.
Yeah. That was kind of grisly. So thank you so much for sharing. And thank you so much for the tireless work that you are doing and for really bringing this conversation into the light for a lot of people.
Thank you so much for having me. It was a joy to speak with you all.
Yes, thank you. I hope you'll come back. Before we go, can I introduce the new puppy to the viewers?
Oh, yes, please.
Yes.
This is Henry.
Oh my
His little ears inside out. There you go. He's sleepy.
He's like the cutest thing I've ever seen.
He has pronouns. His pronouns are sniggle and wiggle.
Are you affirming him?
I'm affirming. I'm very affirming of this dog.
Oh, so sweet. Thank you for introducing us to Henry. All right, you guys. Thanks to everybody who joined us in the chat. We'll see you guys next week.
Thank you so much.